was resuscitated. You cool these patients to preserve brain function because it's brain death that kills them. They have to have protocols for putting in what we call percutaneous left ventricular assist devices. These devices basically do the work of the heart while the patient is completely incapacitated. There are protocols for neurologists to actually judge how the patient's doing and care for that. And then the ability to plant an AICD. I think everybody knows what that is. That's what Damar Hamlin had planted after his terrible event so that he continued playing NFL football. Level 2 is the same, except they don't have open heart surgery, and they may or may not be able to put in this LVAD device. And then the level 3 hospitals in more rural areas have prearranged protocols so they can get people to a higher level of care. And they also have to be able to do that temperature management. So this is how it works. In the top left is our patient. The paramedics get a call. They go to the call and they evaluate the scene and what's going on with the patient. If they're close to a level 1 hospital, over there in the bottom right, they can take the patient directly to a level 1 hospital. However, if they're closer to a level 2 or a level 3 hospital, patients can be stabilized there, and then the protocols are set up to move them to a higher level of care. There are 19 level 1 hospitals in Georgia. There are only 2 open heart surgery programs that are not certified, and they're pending certification. There are 19 level 2 hospitals, and 5 of those are pending, and 5 more pending certification. There are only 10 level 3 hospitals, and 7 of them are pending review. But it's these level 3 hospitals that are important in our state. You can see that it canvasses the state, but we need more of these level 3 hospitals to make sure that everybody has an equal opportunity to get the great care. And over the next 12 to 18 months, almost half of the Georgia hospitals will be certified. So there are 3 people that run the Office of Cardiac Care. A 4th member is funded separately. She's an epidemiologist, and she tabulates the data that comes into the database. They've had great accomplishments. They've tabulated 4 years of emergency cardiac care data for STEMI and out-of-hospital arrest, and the mortality rates in Georgia are actually going down because of these protocols. They've devised new programs for STEMI with cardiogenic shock. If you have a heart attack and you're in shock, your chance of living is less than the flip of a coin. They've increased pre-hospital activation so that paramedics on the scene make a decision. They radio in, and everybody on the team at the hospital is then waiting for the patient. They're advancing protocol about using anticoagulation before STEMI. And we now know for the first time, if somebody asks you how many STEMIs are there, you can tell them. It's at the top left of that slide up there. I know it's small. There are about 3,500 STEMIs in the ECC hospitals and over 5,000 out-of-hospital cardiac arrests. And here are the data about survival. In the gray bars up there are 2021, in red is 2022, and in blue is 2023. And you can see since the initiation of these protocols that the total deaths in all of these, out-of-hospital arrests, STEMI, and cardiogenic shock, is going down. So what about the death rates versus the funding? I think this is where we need your help. And like I say, I'm here as an individual. On the far left is the cardiac care centers. 24% of people in Georgia die from heart disease, and their funding is $500,000. Stroke, 5.2% of people die from stroke, and they have about $3 million. Trauma, 7.7% of people die from trauma, and their war chest is about $22 million, and they get $7 million a year. Shown a little more graphically, the font size in this slide represents the numbers, so that you see the death rate of cardiac versus trauma versus stroke, and there's the funding rate. Thank God for all the people that speed. We need great trauma care, but an enormous amount of money goes to the Trauma Commission, and $3 million for the Coverdale Stroke Program. Here's this in a table that you can look at later, but it shows the number of hospitals that are certified. And finally, I want to get to maternal mortality and cardiovascular disease. We have a big problem with maternal fetal mortality in this state. I think everybody knows about it. It's been in the newspaper. Well, it turns out that if you look at maternal mortality over a year, 53% of women die from a cardiovascular problem within the first year of delivering a baby. And if you drill down a little more, hypertension and pulmonary emboli, which are often considered cardiovascular causes of death, If you added all that, it would be about 63% of maternal mortality in the first year occurs from cardiovascular disease. So in conclusion, cardiac disease is the #1 cause of death in the United States. 1 in 4 of us will die from that. These time-sensitive emergencies, we've shown in Georgia we can decrease the death rate. Cardiac disease is the #1 killer for women after childbirth. And I think I've shown you data that the Office of Cardiac Care is underfunded. So what am I here to ask? Costs to these hospitals, especially rural hospitals, exceed the payment for the care of these complex patients. So a lot of the rural hospitals are not getting involved in the Office of Cardiac Care and Emergency Cardiac Care Network. They have to have 24/7 coverage. They have to allocate resources every day of the year. And if they had some fiscal support from the Office of Cardiac Care, we could improve outcomes even further. And I think belonging to the Emergency Cardiac Care Network in Georgia would encourage innovation in these hospitals. So by investing what we have in the Stroke Commission or the Stroke group, we could do an enormous amount of things. And in your packet are 2 pages at the very end or 3 pages that show the justification for actually paying for each time there is a STEMI alert at these hospitals, and I think we could help them out. Where could the money come from? This may not be popular, but let's face it, smoking is one of the #1 causes of heart disease in America. More importantly, girls are catching up with boys. If you look at the quartile of young women aged 12 to 17, they've almost caught their male counterparts in smoking. Now that's bad for those ladies, but it's also bad for their babies. If a woman smokes more than a pack of cigarettes a day, there's a 56% higher risk of fetal and maternal mortality. So all this is linked to smoking. Finally, this is something that the Office of Cardiac Care and a number of us in Georgia have put together. It's a statewide program done once a year where the nursing group, the emergency physicians, the cardiologists, GEMSA, our EMS professionals, and DPH get together to try to innovate here. Thanks for your attention.
Question?
Yes, I do. Okay.
What's your mic level?
Oh, sorry. Okay. Sit on. Okay.
Representative Cooper.
Maternal mortality is a big issue with me. When I go back to the statistics, you said 60% or 40% of the mothers die.
If you look at in the first year, 53% of mothers die from a cardiovascular problem. That doesn't include hypertension, preeclampsia, which is a predictor of long-term mortality. So that's broken out separately, which is 2%, and then pulmonary embolism is another 8%. So it could be as high as 63% within the first year of women after childbirth die from cardiovascular problems.
Okay. Your statistics, if you're saying that, we have 110,000 births a year. 60% of those women are not dying.
No. Of the deaths, of the total number of deaths.
Well, you didn't say that.
I'm sorry, I apologize.
I mean, it's very unclear.
Okay. Of the
And
total
what-
number of maternal deaths, 60% of them are from cardiovascular disease.
Right, and we have about 35 or 40 maternal deaths a year.
35 or,
40.
okay.
Out of 100 and somewhere, depending on what year it is, 110, 120, and some years 130,000. I mean, I say that to you because when you come and present to us and you don't get down to that, it makes the maternal mortality, and people have exaggerated how bad it is. Now, I wish not one mother would die.
Me too.
But considering we have somewhere, let's say 120,000 deaths, 35 to 40 is not a huge amount. Too many? Too many. I wish we could get it down. But we have scared black and brown, especially black and brown mothers across the state, to the point that they want to have home deliveries or go to a doula or something like that, which is even more threatening. So it just happens to be, if you could be very specific when you get to maternal mortality, Dr.
Thank
Marshall.
you. I appreciate that. I didn't mean to mislead anybody.
Well, on maternal mortality, it's really
I know it is, and we've put several ladies on ECMO following their delivery. during COVID and after COVID. So cardiovascular disease is a big problem.
And, Mr. Chairman, if I may,
Yeah, go ahead.
one of the problems we're having too in lowering that rate is that many of these mothers live in areas where there is no cardiologist. And we have tried to set up and have been some successful of setting up with cardiologists in other places to do telemedicine and try to help us with that. And there has been some reluctance for them to do it. I think it's maybe over the malpractice, but anything you could do to help us set up that kind of a relationship so that mothers who we do pick up that have cardiac problems could get treatment.
Yeah, I am aware that MAG has a phone app now so that people in rural areas can contact a cardiologist.
We're trying.
And yeah, I think that that's a great solution. Thank you.
Okay, any more questions? I want to thank the presenter for coming today. Whether it's 20 or 200, 6 or 60 is too many. And overall, we could do better with our care in this state, especially with cardiac events. And I appreciate you bringing this. I hope that we can work to a place where we can find some money to increase the funding for Office of Cardiac Care. I know that Chairman Taylor was in here. I think she had to leave, but she was listening to part of this, and I want to thank you. Thank you.
Thanks for having me. I really appreciate the opportunity.
Yeah. Don't go far because we got this one. Okay, we're going to go out of order because Dr. Marshall wants to speak to 197, and that's a bill that I'm presenting, so I'm going to go down there and turn the chairmanship over to the Vice Chair, Representative Kelly.
Chairman, you ready?
Yes, thank you.
All right, for the committee, we're working off of LC 461010. Chairman Hawkins.
Thank you, sir. Thank you, Mr. Chairman. It came to my attention years in the past about a problem that we have or a challenge we have in delivering health care to patients in this state and actually around this nation, and that is dealing with third parties and sometimes denial of treatment. I've been working with Jesse Wethington since spring on this bill. It's a simple, straightforward bill that addresses this. If you look at lines 21, it starts, such effort shall include contracting the treating provider or his or her designee, implementing a callback telecommunication system, or the use of a public website whereby such provider or designee may elect to receive a scheduled communication at a later time in the event that the clinical peer is not available. What this means is that sometimes a physician or dentist will get a call while they're treating a patient. It is impossible for them to turn away from that patient, so we miss the call, and it may be days or even a week or so before we get another call. This bill will arrange an agreed upon time that the physician, dentist, or healthcare provider will be available for the call, or they can do it, by computer contact. I think we have. Do we have the Facebook post from Dr. Grunch? Now, I've never done this before. Does it do something?
And I've never had this happen before, but during the second deep, I had a phone call into the operating room saying that United Healthcare wanted me to call them about one of the patients who was having surgery today, who was actually asleep having surgery, and said I had to call right now. So I scrubbed out of my case and I called United Healthcare
This is plastic surgeon Dr. Elizabeth Potter talking about her experience when United Healthcare called her during the middle of a surgery about the patient on the table and wanting to talk to her about whether or not the patient needed an overnight stay. And a lot of people in the comment section were wondering, like, does this really happen? Would a surgeon really have to scrub out to talk to an insurance company? As surgeons, the reality is we do this all the time. And that may seem incredibly shocking to many of you, and it should be shocking. There are two main topics that I want to talk about with this video. Is one, why an insurance company would want to speak to a surgeon during the middle of a surgery about a patient's health care. And number two, should a surgeon really be scrubbing out to talk to an insurance company about someone's surgery? As a spine surgeon, I do peer-to-peer conversations to try to get my patients' surgeries approved about 30% of the time. That means for surgeries that I want to perform on a patient that I think is going to make them better, I have to personally speak to an insurance physician in order to get that surgery approved. That's reality of healthcare in the United States right now. I am also a surgeon that's in the operating room 3 to 4 days out of the week, which means inevitably I will get phone calls while I'm in surgery. Fun fact is, for the most part, they don't really give you a choice as to when you can schedule these peer-to-peers. So if I don't answer at their beckoning call the second that they call me, that patient's surgery may be denied. So I have to answer that phone call when they call, or my patient won't get the surgery that they need. They put us in these positions so there are more roadblocks along the way to getting patients care. And having these conversations when you're supposed to be focused on the patient may seem shocking to some, but as surgeons, we're really good at multitasking. During surgery, we may also field phone calls from the emergency department about other patients that may need our care, or our office about other issues with other patients. So while focusing on the procedure at hand, there are other things that we have to also focus on. I will admit that what she is discussing is an insurance company calling about that patient that's on the table. That is pretty rare. But the general concept of what she's trying to prove is that we are forced to advocate for our patients at all times of the day, whatever we're doing, at their beckoning call. Because our fear is that if we don't answer that phone call, our patients won't get the care that they deserve. Oh, no, because it's not as simple as letting it go to voicemail and calling back. You have to completely reschedule, or they will deny it outright. And as surgeons, we would never divert our attention away if there was something that was happening on the table that needed our attention. But there are many times in which we do have to do this. And the question is this right? As physicians, as surgeons, this is our reality.
Okay, thank you. Mr. Chairman, let me also say that working with Jesse Wethington, who represents the healthcare insurers that operate in the state of Georgia, this is not the profile of every health insurer in the state. And he has assured me that those that may be requiring these calls now agree with this piece of legislation. I think you have someone who wants to speak right behind me. The reason we moved this bill up, that's Dr. Jeff Marshall.
Thank you, Mr. Chairman. I don't see any questions for Chairman Hawkins, so why don't we go ahead?
All right.
Representative Census.
Chairman, I'm just going to ask, is it possible to know which insurance companies do require these type of peer-to-peer?
No, we did not have that conversation.
Okay.
My focus was to make sure that people had access to health care in a timely manner, and who was doing what really does make a difference at the end. We're all going to be able to access care in a much more timely manner with this bill being passed.
Right. I like the bill. I'm just
Thank
curious
you.
to know about
Yeah.
what insurance companies, because I dealt with that a couple years ago. So thank you.
Thank you.
All right, thank you, Chairman Hawkins. We'll now move to the individuals who have signed up to speak. We have Dr. Jeff Marshall and Anna Ruzicka from MAG.
Hi, everyone. My name's Anna Ruzicka. I work for the Medical Association of Georgia.
Hi, I'm Jeff Marshall. I'm now here as an advocate for the Medical Association of Georgia.
Thank y'all.
So I was asked to maybe give y'all a firsthand, in-person idea of how this happens, and it happens frequently. I'm an interventional cardiologist. We do cardiac caths, which is an invasive procedure where you take a small catheter to the heart to take pictures of the heart, and then after that we can put in stents, or we might send you to open heart surgery. It used to be that we could do that with the right indications. Now most of the time that has to be pre-approved with almost everybody. And what happens is they will sometimes give you an appointment, sometimes they won't. I've waited or had my staff, running in and out of rooms. We may wait 45 minutes or an hour for somebody to get on the phone to then rush out of a room to come out and explain why this patient needs it. And I have a few anecdotes of times where things happened where they didn't get approved, where bad things happened to people. And I don't want to fill you up with anecdotes, but every cardiologist, every physician would have one. Some about young people with heart disease and family histories who have stress tests that are positive. They can't get the test. And some of them have heart attacks in that interim. And a very few of them have then come in and got the cath and gone immediately to open heart surgery. So this happens daily. That YouTube, or I don't do Facebook, whatever that was, that's real life for me and my partners every day.
Thank you for sharing. Any questions for Dr. Marshall or Ms. Rusica? If you'll just spin one of those mics around, Chairman Parsons.
Well, I'm sure that Chairman Bill will take care of this, but I'm trying to figure out, I don't know why that, like this surgeon that was talking, I don't know why she wouldn't expect to get a call. Is it a yes or no answer, or is it an involved explanation why you have to?
It's often a discussion, and sometimes as a cardiologist, I'm talking to a pediatric endocrinologist trying to explain to them why you might need a heart cath because you have this family history, your cholesterol is high, you have high blood pressure. You need a cath so we can determine whether or not you need a stent, you need medicines, or you need open heart surgery.
Well, if the surgeon's in the middle of the operation, like they were talking about, would there ever be a scenario where they would be denied in the middle of the,
if you don't do the peer-to-peer, you get denied and you have to restart the process.
But if they're in the middle of a surgery though, and they get this call, it seems like that. Do they ever deny that when somebody's actually on the table getting a surgery?
I have to say that's never happened to me. That's while I'm doing a heart cath or an angioplasty that somebody calls into the cath lab because they don't know how to get me.
Okay.
And so I don't answer my phone when I'm paying attention to that patient that needs my help. But in the office, it's a daily occurrence.
Okay. This is my life. It seems like as a non-surgeon and non-doctor, the answer would be yes. They need to have this approved and move on with the surgery.
But that's not how it works.
Okay.
The issue is, so the reason that they have the peer-to-peer calls is to determine medical necessity. So if the insurance companies don't believe that the surgery is necessary, they would have this peer-to-peer. So that's why it's important for the surgeon to be on that call to explain why their patient needs this surgery urgently.
Okay.
So there are cases where it does get denied if the insurance company doesn't view it as a medically necessary service, even though that surgeon does.
And they just pull the patient back out of the surgery and. Okay.
That's why we need to have these scheduled.
Well, I'm sure
so
that the chairman's bill takes care of it. I'm just trying. Just questions that come up to me, and it's
Definitely,
probably don't make any
it's a
sense to
very
anybody else,
complicated
but-
process, and the prior authorizations are a huge burden to our physicians and patients. So that's why this is a great step forward to ease it a little bit and try to prevent that delay in care.
Scheduling this would make our lives better.
Thank you for that. Chair Lady Cooper.
Representative Parsons, there are cases where they've already been approved and they changed their mind, the insurance companies changed their mind, and patients have already been in pre-op, have already had their IVs and their sedation started. And it's pulled retroactively. I don't know of a specific case when they're in the middle of the operation. I don't think the physician would stop. They would finish it and maybe just not get paid. But there are lots of cases where they do it when they have been prepped, ready, and already been given the medicine to make them groggy and all for surgery.
Thank you for that. Representative Clark.
Thank you, Mr. Chair. So just to provide a little bit of context for everyone, how many of these peer-to-peer calls would a surgeon have, let's say, in a week? Yeah.
It depends on how busy the surgeon is and what kind of surgery they do. I suspect for doctors like Dr. Grutch that are doing spine surgery, which, there's a lot of decision-making in that kind of surgery, that she's probably doing it all the time. As a cardiologist, I'm doing it 3 or 4 times a week if I can't get my advanced practitioners to do it for me. This is a huge burden for doctors, huge.
And so a follow-up to that. So if you have, let's say, 20 patients that week that you are planning, I don't know if that's a realistic number, but let's just say 20 patients, do you have to do a peer-to-peer for all 20, or is it a case-by-case? Like, how does that work?
It's case by case, but when I started practicing in 1991 at Emory, the number was 0.
Okay. And what would you say the number is now?
I can't honestly tell you what percentage it is. We have
Okay.
we have a staff of almost 100 people in the offices that do these pre-certifications.
Got
And
it, okay.
I have, my brain's not big enough to remember all that, sorry.
It really
That's
does
fair.
vary by specialty, by insurance carrier. There are a lot of different factors. So in my research as well, anecdotally you hear physician by physician, but overall it really varies.
Okay, thank you.
Thank you for the question. Representative Schofield.
Thank you. So I'm curious, with the peer-to-peer reviews, does the practicing physician get to know the name or the ID number of the insurance company and like peer docs, and does this bill address any of those type of things?
I don't know about the bill. I know the bill will give us a specific time, which will make our time be used more efficiently. But I will often ask, what's your specialty? Sometimes it's a cardiologist. That makes the discussion very easy. But sometimes it's a psychiatrist trying to help us with how to figure out a cath. They don't have to give you their NPI number.
Right.
They're protected by law for liability. So, and that's one of the things that really rubs practicing doctors the wrong way. If waiting for this pre-approval, if something happens to the patient, it's on me and my team. But the person at the insurance company has no liability if things get delayed. And that's particularly bothersome to lots of practicing doctors.
Yeah, that's what I was concerned about. Thank you.
Yes, ma'am.
Thank you, Dr. Marshall. Don't see any other questions. The one I'll kind of just maybe put an exclamation mark on. Do you think this process has resulted in you not being able to provide the quality level of care that you think patients in Georgia deserve, this process?
I think the process has, like everything in life, has a good side and a bad side. This timing would make it better. I can tell you a story about a young man who was denied his asthma medication. They said they wanted him to take the less expensive alternative. He tried that. He had an out-of-hospital cardiac arrest and ended up on ECMO, which is a heart-lung machine, for a couple of days until his asthma could resolve. So, yes, it can hurt patients. I don't think that's frequent. I have no idea what the numbers are. But sometimes us being able to have this peer-to-peer discussion on in a timely way and convenient for both parties would certainly help protect Georgians.
Thank you for being here today. Chairman Hawkins, do you want to close before we look for a motion?
I want to make it clear that this is not just for surgery or not just for cardiologists. We face this every day, even in the world of dentistry. This is for your regular physician, your family physician. This is for the pediatrician treating your children, or the physicians treating your parents or your family or your wife or husband. It happens every day in medicine and dentistry. There are reasons I assume that they want to make sure that the patient is being treated with necessary treatments, but I can tell you, I don't know of a physician or a dentist that does something that a patient doesn't need. I'm sure there's some out there, but I don't know of them. This bill will help it increase and improve the time of access to care for all patients with all health care. That's it. Thanks.
All right, thank you, Chairman Hawkins. Don't see anyone else signed up to speak. We have heard the presentation from the author and had robust questioning. The bill is now before the committee. What's the pleasure of the committee? All right, we have multiple motions do pass. Do we have a second? All right, multiple seconds. Any discussion? Chairman Newton?
Thank you. I'm just going to point out that this is a concise and precise bill, and just like the surgeon in the picture, the beauty of it, I believe, that by saying if they're not available, which if you're sitting in your office, it's fine. They do it like they've always done. But if they're not available, you got to have one of these other two options to schedule. It's a simple thing that's done on the internet for anything where it says contact us at the bottom of a website. I think this is a great bill to take care of this, and it also protects that patient. Now, as an ER doctor, I call people, and they're in the middle of surgery, and they talk to me on speakerphone, but those are emergency cases. These peer-to-peer are not. This is just an excellent solution that also helps the patient who is on the table, whose approval isn't in jeopardy. It's tomorrow and the next week's patient that you need to talk about. So I love the idea of the surgeon working on my family, not being distracted, if they know they're going to have a specific time and an easy system to get their job done that's important for the patients tomorrow and next week. I appreciate you doing this, and I appreciate great bill.
Thank you, Chairman Newton. We have a motion. We have a second. I see no further discussion. We have the motion do pass pending for LC 461010. All those in favor make it be known by saying aye. Aye. All opposed, like sign. Bill passes unanimously, Mr. Chairman.
The next bill that we're going to be taking up is a substitute to HB 196. That's LC 570229S. This is by Representative Trey Kelly. When you're ready.
Thank you, Mr. Chairman. Members of the committee, as Chairman Hawkins said, I'll be working off a substitute to House Bill 196. The LC is 570229S. And, Mr. Chairman, while this is a new bill before us, it's not a new effort. This is the continued and renewed effort that this committee and this House chamber has undertaken to lead when it comes to making sure that patients across our state have multiple options when it comes to getting their prescriptions filled. This is an effort that is aimed at driving down cost of prescriptions for our consumers across our state, and it's something that I think many of us on this committee have had the opportunity to speak with our local independent pharmacies in helping them keep their doors open. Simply what the substitute before us does is it creates a reasonable reimbursement rate for our pharmacies, all of our pharmacies, when they fill a prescription. It does that if you look at the equation as it's referenced starting on line 51 running through 59, and it says that an insurer shall reimburse a pharmacy for a drug dispensed to a covered person for self-administration in the state health plan. That's something important here. We are specifically focusing on our state health benefit plan, so our state employees and our university employees, and so they will have an opportunity to be reimbursed an amount equal to the sum of the national average drug acquisition cost, the NADAC cost, and if not NADAC, then it goes to a couple other factors, along with a professional dispensing fee that is not less than the professional dispensing fee paid to the state under Title 19 of the Social Security Act. Mr. Chairman, the bill's fairly straightforward. It's a subject matter that we have seen multiple times when we're talking about our pharmacies getting what I consider just a reasonable floor when it comes to the reimbursement rate from our pharmacy benefits managers that are administering our state health benefit plan. I know there's some other people that may be here ready to answer questions, as am I, but I think again, as we just wrapped up one conversation about making sure that patients in Georgia have an opportunity to see the providers they want, to use the pharmacies that they choose. This is another step in providing patient-centered healthcare solutions for Georgia, while also benefiting so many of our local and independent pharmacies, which provide so much back to our community. I'll be glad to answer any questions, Mr. Chairman.
Do you have a question? Representative Stinson?
I think it's.
No, it's not.
Oh, go ahead.
Thank you, Mr. Chair. Thank you for bringing this bill. Just very curious, the difference between the original bill that ended in 0203 and the difference and 0229S is the definition of insurer. Can you just kind of?
There's actually been, this is my second substitute.
Okay.
And I always believe in, perfecting bills as we move through the process. So the first thing we did is we made one small tweak at the request of one of our state-ran or one of our HMOs that administer for the state. They had been inadvertently left out. They had been carved out as an exception because they're extremely unique. And so we just added them. We'd already excluded them in one section. We excluded them in the other. So that was really a technical cleanup. And then second, when I talked about that equation, it was a three-step equation where you also had, in addition to the NADAC cost and the dispensing fee, you also had a additional payment of 4% of the NADAC cost or $50, whichever was less. Trying to listen to some of the concerns from DCH as it relates to certainty and predictability for the cost, because since this is a state health benefit plan, anything we do here could have an impact on the state appropriation that's needed. And I'll be clear, as we move through this process, there was a reason I had Chair Lady Taylor sign the bill number 2 and Chairman Hatchett sign as number 3, and that's because we're going to make sure that we have the appropriate appropriation made in the fiscal year 26 budget to cover this cost. And so those were the two changes that were made. Thank you for the question.
Thank you.
Okay, I see no other questions. I would like to ask DCH a question or two, if you would come to the mic. Okay. Can you identify yourself in the mic?
Maybe.
I think we all know who you are.
Mr. Chairman, I'm Dean Burke. I'm the Chief Medical Officer at Department of Community Health, and I have oversight of the State Health Benefit Plan as one of my duties, and I'm very lucky in that the organization's highly professional. I have our Chief Pharmacist here and Director of Pharmacy, and Lori Garner has been with the agency many years. I'm not going to say how many. And certainly knows way more about these intricate details of contracting than I do. So if it doesn't take long to get over my head, and I'll let her help me out. So.
Well, this question is to either one of y'all. It's my understanding that there are some administrative fees, additional administrative fees to implement this bill. Can you explain how that works and how the department got to these fees?
Yeah, I'll do a quick overview, and then I'll let Lori get into the specific details. Of course, the fiscal note was provided on the original bill that was evaluated, and the process for that, as most of you know, is we have to evaluate the bill as it's written for that day. And so we had our actuaries and of course our vendor, which is CVS, to answer our questions about if this were to happen, what would it cost? And so the fiscal note was returned, and as far as the specifics on the CVS piece of that, I'll let Lori mention it, or get into the details. But that's where that information came from.
Sure, I can probably. Mr. Chairman, members of the committee, we had Aon, as Dr. Burke has indicated, provide us with the cost associated with the pricing outlined in the bill specific to what would come out from a claim perspective. And that was done by Aon Consulting, an external party who did the analysis based on our claims volume in calendar year 23 for a full year purpose. We then needed to get some administrative costs associated with the particulars of how you operationalize that actual payment mechanism from a PBM's perspective. So we did ask our incumbent PBM, which is CVS Caremark, for the pricing that, based on the way the bill read at the date that we had asked for the fiscal note, what the cost would be associated with that. While we recognize in an ideal world that would be fees you would probably negotiate through a procurement process or with your existing vendor as things move forward, given where we are at this point in time, we had one source, and that source was our existing PBM vendor, and that's who we received those rates from.
Oh, thank you. The committee does not have these numbers, and I don't know that we need to get into these numbers right now because we don't have a fiscal note, right, Representative Kelly? Okay. So I think you pursue it to all fairness and all the work that you've done. Are there any more questions? Do I hear a motion? Oh, Representative Jaspers.
Thank you, Mr. Chairman. I'd just like to make a comment more than a question, and just thank Representative Kelly for his leadership on this issue. There's been lots of interest. All of us have received numerous emails from our independent pharmacies and been so kind and so positive. That's the way to do it, and I appreciate them doing that because they're crying for a balanced approach to this, and the closing of our local small town pharmacies is travesty, and I hope this helps.
Thank you.
And if I could, Mr. Chairman, just to wrap up, I want to say thank you to a lot of the partners that have been here, certainly our local and our independent pharmacists. I've heard countless tales of them having to either make a decision that benefits their patient or a decision that benefits their business. One of the most heartbreaking was one from South Georgia where a pharmacist was going to provide a specific cancer drug for a child and then a pretty standard prescription for a senior citizen. And between the two, that pharmacist lost about $600. And the choice was either they let these two people who need these life-saving medicines, they provide them for them, or they either ask them to go somewhere else. And that's the opportunity that we have to address today. I appreciate DCH for being good partners working with us on this, and I appreciate those in the appropriations process who have a passion for this, Chair Taylor, Chairman Hatchett, who are going to make sure that we do have the appropriate state appropriation to make sure this gets implemented this year. So thank you so much, Mr. Chairman.
Oh, you're welcome. Okay. Do I hear a motion?
Motion to pass.
Second. All those in favor say aye.
Aye.
All those opposed? Congratulations. You have one more question now?
Just a quick.
After the vote?
I voted for it.
You. I'm going to give you some latitude, big boy.
Thank you, Mr. Chair. Are we going to pass this without the physical note, without knowing what the note is, or is it going to be added to it later?
It's going to be added to it later.
Okay.
Yeah.
Okay. Thank you.
You're welcome.
I'll bring it to you firsthand because I know how much you care about this issue, and I know you have legislation to address some of these concerns we have with PBMs as well that I was proud to sign on to you with. So I appreciate the work that you've done in this space as well. Go Dogs.
And let me answer your question, because that's a good question. The fiscal note is ongoing right now. There was a change in the bill today, and rather than holding the bill up, is pursuing upon DCH to give us another fiscal note, and they're working on that. So you will be provided a fiscal note in the future. Okay?
Make sure there's enough.
Okay, well, I want to say to Representative Kelly, congratulations on your bill, LC 5702229S.
Thank you, Mr. Chairman.
Thank you. Okay, up next, Representative Dempsey with House Bill 218. And this LC 461009.
Thank you, Mr. Chairman. That is correct. That is correct, that LC number. So this is a fairly simple measure. In 2022, I carried a bill that many of you supported at that time, HB 1086, which simply made an offering of flu vaccines for someone as they left the hospital, a patient who was leaving. It was an opportunity to deal with the serious issue, of course, of flu. If anyone has a chronic condition, it certainly becomes really challenging to catch the flu. Can impact their glucose levels and also things like pneumonia, heart attack, or stroke. So it's simply a precautionary offering. It will be offered at age 50, not mandated, not told. Anyone can answer yes or no. But it has been discovered that perhaps we should look at this at a younger age. So looking at changing one thing in this bill on line 13, changing the age from 50 to 18. That does allow not to in any way complicate parental permission to do that. So it is a young adult at age 18 that can say, yes, while I'm here before I leave, if you will go ahead and give me the flu shot. Also, for cost concerns, the Affordable Care Act mandates that insurance companies cover the cost of an influenza vaccine, and recently passed federal IRA law requires that Medicaid cover the vaccine as well. So it's not a cost to the patient or to the hospital.
You have a question, Representative Clark. I think.
She just answered my
Okay,
question.
good. Any other questions? All right, great. Do I hear a motion? Do I hear a second? All those in favor? Congratulations. You have a due pass, Representative.
Oh, you're lucky.
Why not?
Oh,
I know.
somebody opposed.
They know better.
Thank
My
you.
Cracker Jack over here reminded me of that. Okay, Representative Dempsey, congratulations. You have LC 461009. Do pass.
Thank you.
Okay, the next bill that we're going to consider is House Bill 227 by Representative Dickey, LC 550411.
Well, thank you, Mr. Chairman and members of the committee. My first time to the Health Committee.
Right.
But I've got a bill I really would like consideration, and I've been around this bill a long time. And 10 years ago, my good friend Alan Peake, who's a neighbor there in Middle Georgia, just worked tirelessly to try to make some cannabis products available to Georgia citizens. And by the way, I'm working off House Bill 227 LC 550411. And so I've got a lot of history with our medical cannabis, low THC oil program. And, you know, he felt strongly, as many of us up here, that certain patients could use that product, maybe not a cure, but at least treatment and a drug for a lot of conditions. And so that's what kind of leads me into this bill, and we've come a long way. We've had lots of legislation, lots of discussion in this building about license, and this bill does not do anything to that. but I've always wanted something that was safe, tested, correct dosage, and was legal. And really what got my interest in the last year, this product is grown in Georgia, grown right in the middle of Georgia, right in my district there, and processed and made into a product right there, right here in Georgia. And that's what really got my interest here. But during all these discussions we had in this bill in the last few years, I think one of the problems is the patients of one who's been ignored and left behind, and that's what this bill seeks to address. And this bill really only does a couple of things, major couple of things, and we named the bill "Putting Georgia Patients First Act," and that's my intent for this. And I really do think our patients' interest here in Georgia has been ignored as we've gone through this legalization process. It is, as I said again, I want to repeat, it does not have anything to do with licenses. So it's really two objectives here. We're going to propose to change the name from low THC oil program to medical cannabis. Just a name change. And that's what a lot of this bill does, where it ever makes reference to low THC oil. And way back 10 years ago, that was the preferred thing to do to make sure it wasn't anything else. But now our Medical Cannabis Commission is what it's called, and so we're just trying to line up the program with what the commission does and a name change, just to let the public better understand what the products are, what the program is. And then the second main thing this bill does, removes severe and end-stage caveats from the qualifying conditions. We don't change or add or take away any conditions. If you turn to the last page or almost last page, all these conditions, multiple sclerosis, cancer, Parkinson's, sickle cell, Alzheimer's, all of them say end stage. And that is very, very restrictive. I mean, I know folks need hospice coming in before there would be available to this product. The bill does not allow for smokable or flower products. It doesn't change anything the commission is allowing now presently in the program. As I said, it doesn't add any new qualifying conditions, new products, and in my opinion, this bill does not allow the licensees to advertise. So the name change is the big problem, and just trying to take away the end stage. It does talk about public awareness, allowing these companies to make aware to doctors and patients on a public awareness type program the availability of this product. So Georgia has five. Here's a little fact that I didn't realize till we got into this thing. The program's 10 years old, and we have very, very, very few people using this product. Arkansas has a 3.5% penetration. Its patient count's 109,000, but they only have a third the population we do. We only have 26,000 patients in Georgia using this thing out of 11 million people, the lowest in the whole country on this with this medical cannabis program. And so it's a fraction of what every other state in the country is. So obviously something has not quite meshed with this program. We're spending a lot of money, a lot of effort regulating it, testing it, doing everything this legislature has told them to do and pass bills, but it's just not being used. And I've seen a lot of misuse of products out there we had some bills through the Ag Committee on hemp, and we're trying to hem in those products all over our state. It's a big problem. Those products, we don't know where they're coming from, where they're made, the dosage, the strength of those, and totally unregulated. And we passed a bill, and all of us passed some bills last year to give Commissioner Harper some legislative and enforcement action to try to hem in those products in those smoke shops and C-stores and those type things. And he's doing that. He's taking that on. And I just rather have our patients using this product that we know what it is. It's tested and prescribed by physicians. That's my interest in it, and that's what the bill does. I'd love to answer some questions.
You've got one so far, but I want to just ask you one first. This in no way increases the percent of THC in the product.
Does not change any of that. Name change, some public awareness, and changes end of life, so folks are able to use it before the end of life.
Right. Representative Parsons, did you have a question?
Yes, Chairman. I support your bill.
Could you speak into the mic, please?
Sorry.
Thank you.
It's just like right there, but
yeah. I know.
Okay. I support your bill.
Thank you.
And about 10 years ago, when those initial legislation came through, Chairman Cooper's bill, Chairman Cooper's committee, back then, I supported all that wholeheartedly, and I knew some people had come to testify. But I'm wondering if the small, and maybe the chairman, maybe you could, we could get some information on this. I'm wondering if the reason the small number that we have in Georgia, I mean, I'm just wondering how effective all that's really been. I mean, I was a real supporter of it, but it seemed like the people that I have known that were big supporters of it to use it, you know, because of all these, I can't think of the name when they have the kids shake and fall down and all that. What's that called? Seizures. I mean, it seemed like that they still are having the same thing. Nothing's really improved. I'm not. It's a question about. I mean, I support your bill, but Chairman, I mean, I would hope that sometime we could get some information about how much good it's really doing. I've gotten to where I just hate anything to do with marijuana. I really do. I hate the smell of it. I hate to be around it. And you get out here on 75, you drive up the road. You can't even drive up the road without being overtaken by it. And so anything to do with this, I just have questions about it anymore. And I'd like to know how, what kind of effectiveness it's been with the whole program. I support your bill wholeheartedly. Thank you, Chairman.
Thank you. Representative Newton.
Thank you, Mr. Chairman. And Chairman Dickey, I appreciate the effort in this, too. I agree. I would love to see more proven science behind it. I know I've raised with you a couple of questions I have, and some of it has to do with lines 268. Some of the part about marketing, in particular. Many of us believe there's probably too many drug ads on television as well, and those are all those are all medications that have met a high bar for FDA approval. One of the problems is that we don't really have FDA randomized controlled trials to prove that this works, other than a few rare cases, the seizures, as you mentioned, and some of the nausea medications. And so when I look at the ability in lines 268 through 283 about marketing by the people growing it that do want to grow the business, and then you look over leaving out severe and end stage, I will tell you as a doctor, there's two different categories here, because a lot of these things that were severe end stage was compassionate use, when you had tried everything that medical science can do and it wasn't working, that as a compassionate thing, we would just add it in to say, well, you're welcome to try this, and if it makes your life better, great. There are some on this list, seizure disorders, but also multiple sclerosis, some other peripheral neuropathy, other things that Crohn's disease that do have good treatments now. What concerned me was if we're allowing advertising, which means people are going to get the message that these may be an effective treatment, like maybe even some scientific evidence behind it, and they forego a proven treatment early, especially early in disease, that combination kind of concerns me a little bit, that people might think that they're making two equal choices. That I heard medical cannabis, some studies say it helps, and I heard, this other doctor recommended medicine works. So I would prefer to get rid of the companies advertising it. I don't mind the Cannabis Commission saying, hey, we offer this in Georgia, and personally, several of these I'd like to keep to when they're.
Yeah. Well, I'd love to have maybe let council answer the thing about advertising. I didn't really think the bill allowed advertising. I thought it was public awareness somewhat. And so also, I really appreciate we have good physicians such as you that counsel with patients about what's treatment and what's things to affect conditions and those type things. And again, these products will continue to be prescribed by physicians before they would be able to get the card that we have now to be able to purchase them. So the patient would continue to go through a physician to do that. But thank you for those comments. But
if I might, I like the parts of the bill where you are allowing, right now we just allow the oil, and the physicians that do get a familiarity with this. It's not technically a prescription, it's just of an advice and all, but they, rather than 3 drops of this oil 3 times a day, the fact that they want to make a capsule that has 3 drops in it and be able to tell them to take 1 capsule 3 times a day. I certainly support that advancement to make it clearly medical. And a certain number of the ones that have severe, I think I'd be okay with if it wasn't for the danger of the people making it, advertising it, and confusing the public. So I don't know if there's a consideration of taking out some of the ability to do the marketing beyond the Cannabis Commission itself. I don't mind them doing it.
We can certainly look at it, but because my intent was not to advertise. We got enough. I thought you were going to mention the trial lawyers advertising billboards. I know we've had enough of that. We really not looking at that. But.
Right. I think the filter here is just what you spoke to. We cannot, or physicians cannot prescribe because this is a Category 1 drug. So we can or physicians can recommend and then give them the card so they can go access. So public awareness, is one thing, but it's still the gatekeeper is going to be the physician in this, and which would require an exam. I don't know any physician that you just call them and say, I want a card. That's not going to happen. Okay, we have some other questions here. Representative Clark.
Mentioned the low numbers of people who are actually using the program, and I'm curious how some of these things are going to, I guess, increase the number of people. But my question actually has to do with the Medical Cannabis Commission. They are allowed now to do public awareness campaigns on this, and it also mentions that they are able to do this for the public, but also for law enforcement and healthcare providers. And I guess my question is on the law enforcement part. What exactly are we trying to make the law enforcement aware that it's okay for people to have this cannabis? Like, how are we? What is the awareness for them specifically?
The bill really addresses that. I think what you're talking to, just clarification that this is product is protected from the controlled substance. It's not changing anything, but just clarification. And it doesn't change how medical cannabis is classified, but just trying to some clarification of that. I think many folks are concerned when they get the card and have a possession of this product. Just make sure they are legal with it. We've allowed it nationally. I mean, it's that they can do anything they need to do. No restrictions on it if they've got the card with this approved product from the commission.
All right, thank you.
Okay, Representative, who we have now, Schofield.
Thank you, Mr. Chair. Like the bill, with the exception, I'd like lupus to be added. Lupus, I would like lupus to be added in this.
Lupus?
Yes. This was, I know I had worked with them years ago on this, and it was omitted. And at the appropriate time, I wanted it added back in.
Are you asking for an amendment?
Yeah, I'd like an amendment, please, to include lupus.
Okay. Okay, Representative Douglas.
Yes, thank you, Mr. Chair. Mine is on a lighter note. I think this is a great bill, Mr. Chairman. Next time you come, like you have done in the past, with your peaches, I think it would be apropos if you bring some good. You get it? Yes, it's just some samples for the committee.
The gentleman knows where
weigh
he's.
in totally on this bill. On the peaches, yes. We just want to weigh in and make sure that the people are getting what prescribed for them in a good social way.
Well, you know what you talk. You're welcome to come back and pick peaches again. You've been to my farm one time to pick peaches.
Yes, sir. Yes, sir. Absolutely. But I think this is a great bill for the committee who don't know that being an ex-athlete, our bodies go through a lot of trauma. It's not like the trauma that these kids are going through and sustaining to on a day-to-day basis. But instead of taking those opioids, I think this is a great method of treatment to keep you off of that, to get something natural in your system to help you balance out and to come back to present state where we won't be addicted to those opioids that are so killing our nation right now. So I thank you for this bill. Thank you.
That's a great point, and that is really one of my reasons for bringing this bill.
Thank you.
Thank you. Representative Clark.
Thank you, Chairman. Just want to say thank you, Chairman, for carrying this bill. Know back in 2015, there was a lot of work put into it to get to where we are today, but really helping the patients. And I know they had the patient listening to where that went all over the state, and it was at different universities throughout the state, and they listened. I know something like over 100 patients, medical and health professionals who spoke on that. And I think we've done a lot, but then we haven't really had legislation that's really put patients first. Right. And I know also, I know there's a question somebody asked, about the data of those who had taken it. One thing I think on the cannabis, there's a stigma, but I know from when we passed in 2015, the majority of patients are over or 50 and older. So it's not, you have these young people trying to get on this to go get high. I mean, you can go smell in the streets. I mean, if you want to do that, then you're going to go another route. I mean, these are patients who are really wanting help, who have tried a lot of things, and so thank you for doing that. Means a lot. So
thank you for those
fully in
comments.
support of this legislation.
Chair Lady Cooper.
Okay. All right. I have a couple of questions. Okay. And
I hope I can answer them.
Okay. And a statement. I think what we're seeing and why did a group of patients come and ask you for this bill, or did a group of doctors that are subscribing come and ask for this bill?
No, ma'am.
Okay. I think what we're seeing is a bill that's being pushed by the producers. Mm-hmm. When we did this, just going back, mm-hmm. one of the things that I said at the time was, when they said there were going to be 3 and 3, all these different kind of producers, was they were saying they could produce so much product that there weren't going to be enough patients to use it. Mm-hmm. And that's what we're seeing. You have these companies that were approved, and they put all the money in it, and now they're finding out that they really can't sell enough of it to make it profitable, which would certainly go to, we should not ever expand it to other companies to start producing in the state. So I think it's being pushed by them. So that would make me, and I think maybe as you look at it's not advertising, there's no definition in here of awareness. And you know how lawyers like to get into our bills, and companies says, well, it's awareness. It's not. We're just putting the television ads on because we're just doing awareness. And that really bothers me because I think we're opening up for advertising. Okay. And the other thing I have, a question. On line 124 in it, It says medical cannabis or a product or products containing an equivalent amount. Okay, I understand that about the equivalent amount, but could that ever be a cigarette? Is it open? A product? I mean, I don't have any idea how you make cigarettes or how you get the product in, but a cigarette would be a product.
Yeah.
So could we have them say, okay, there's the opening in the law, which the governor was against, and all of us pretty much at the time said we didn't want to go that route. And that worries me. It also worries me if it's products like gummy bears. In Colorado, and there's been studies post-op, they're having a terrible time with children going to the children's hospital because parents get high and there are children that can eat the brownies or the gummy bears and they're ending up in the emergency room because, well, why wouldn't a little child, want to eat gummy bears left over? And they're also, not only are they having it there, believe it or not, but they're having, the vets are getting more animals because apparently lots of animals like brownies and that kind of thing too. So that really concerns me about the bill, is that the products is so open, but especially if that could open it up to cigarettes.
My understanding is, hopefully this bill, Madam Chair, does not change the products. I think that is in code. I don't know if we got somebody from the commission here. I think my intent was not to change any products at all of what is allowed now. And I hear your caution, and I don't disagree with you.
Would there be some way for us to change that?
We could ask let council do some research to make sure. But my understanding that this language did not change definition of any product.
And maybe the awareness, get a definition of what awareness is.
Yeah, we could work on that.
So
okay.
That.
Representative Kelly, I think you can shed some light on this. Go ahead.
I kind of had the same kind of concern as what would be a product. And so I went back and tried to cross-reference some of the references on. So the first line, 216, it says hemp products shall have the same meaning as Code Section 223.3. And so when I pull 220.23.3, I'll just read it for everybody. It says, hemp products means all products with the federally defined THC level for hemp derived from or made by processing hemp plants or plant parts that are prepared in the form available for legal commercial sale, but not including food products infused with THC unless approved by the United States Food and Drug Administration. So I think there's a federal check on what the U.S. FDA classifies as an eligible product. I think that may address part of the concern there of whether they would allow it to be classified as a cigarette. The second area is we do define product later as it relates to low THC oil. Now medical cannabis product means on 229 delivered through an oil, tincture, transdermal patch, lotion, or capsule, except as provided for. So that I shared some of your concerns, and I got cross-referencing a little bit, and that may.
Thank you.
Thank you.
Is there a possibility of adding in the definitions awareness, a definition of awareness, or or what we mean by advertising? Because I'm with Dr. Newton on that. I mean, I believe they ought to take all the ads for medicines off because your patients go in demanding it, and having had a husband and been in the room with him when patients were demanding a certain pill, I mean, they get really bad, and it's not always what they need, and sometimes it might be that they might not need to have this medical marijuana, but it's
You're asking good questions. Representative Kelly's got a comment on that one too.
I want to ask. I want to ask because I want to make sure we're talking about. You're looking at Section 3.3, where we're talking about what the actual Cannabis Commission can do. Correct? Because that's where I see awareness. It relates to line 243 and it references back to what are the responsibilities of the Georgia Access to Medical Cannabis Commission. And it said that this would allow them to engage in public awareness activities concerning the medical cannabis program. I think, and then it goes to say that could be, include, not limited to, publishing materials and conducting outreach and public activities to inform, that as we run through 243 to 248. And so that is, I view that, at least, and I've been wrong up here a lot, but I read it to mean that we were talking about the actual commission. If there was any, kind of public awareness, or call it advertising campaign, it would have to be initiated through the commission. But then on the page right after that, on 268 going through 271, the producers of the oil or the medical cannabis, they can only directly advertise to physicians and healthcare providers. They can't. The producers can only, and to the author of the bill, that was my concern, or my question is: direct advertising by the producers only allowed to physicians and healthcare providers, and the only ones who can advertise to the public or make the public aware would all be driven through the commission. That's why I guess I was trying to get clarification on too.
Representative Clark.
Yeah, thank you for that. I think the confusion is line 274 and 275, because it says clearly that the licensees cannot advertise except to providers, but then it says, but they can to the public give information about its safety and legal uses and things like that. And I can imagine a licensee seeing this and interpreting that to say, as long as I'm not saying buy this or that, but as long as I'm saying we have available this thing that is safe and all this stuff, that they could interpret it as still being able to go put an ad on TV. They just would have to, they would walk up to that line of, is that?
Okay.
Yeah.
Okay.
I mean, does anyone else interpret it that way, or is that the intent of those two lines, 274 and 275?
Yeah, we can strike it.
Okay.
I would yeah, somebody needs to make a motion to do
Okay.
it. Yeah, Chairman Cooper.
We gotta get the due pass on the bill first.
I'll make an amendment.
Right. Okay. Are there any more questions before we start striking and do the amendment? We need to see if there's a movement on this bill. Do I hear a motion? So moved. Second? Second. Okay. You want to go ahead?
Thank you. I would like to
Chairman Cooper?
suggest an amendment by striking line 268 through 283. And I believe the author is in agreement with me on that.
Okay. So strike lines, would you
Well,
repeat
except
that one
for
more
the
time?
Except for the reference, oops, wait a minute. We would not take out the reference to medical cannabis where it says, where it's strike. On line 268, it would say licensee shall advertise, not market, okay, shall not okay, how do I do it?
Licensee
Shall,
advertise or market medical cannabis.
Right.
So you're striking low THC.
Let's go at that one more time, because I'm not following. You're talking about
Okay.
on line 268, you want to do what?
right, on 260, okay. On 268, it would still strike the no. And on 269, what? It would,
Strike all that. And keep the capital. It
You
says
just need
no
to strike
licensee. You want to say no
274 and
Okay, here we go.
275.
All right.
Okay. 271 out.
our former senator, my former senator helping me out here, on 68, you would strike, beginning with 1, you would strike, except as provided in paragraph 2 of this subsection, okay?
Comma no.
Comma no, and then,
And keep no Capitalized.
You'd keep no capitalized there, and the license shall advertise or market, and then go to low low THC. You would leave that marked out, and then you would have the medical cannabis and go on from there. And then you would strike 271 through 283.
All the new licenses.
So, yeah, so 268 would read, the licensee shall advertise or market medical cannabis or products to registered patients or the public. No licensee. You're supposed to have no in there. No, you'd strike, yeah, you'd have no licensee.
Is everyone following that?
No.
You wish to speak? You got your hand up, does that mean yes?
I don't think this is working. Oh, it is working, okay. But if you're going to say, except as provided in paragraph 2, and you're striking all of paragraph 2, then arguably you don't need 268 and 269 either. If you're striking all the way down.
Okay, the lawyer's doing it.
I love our lawyer.
Thank you. Thank you. That was about it.
Yeah. Yeah, Mark got issues with something like that. He told me that.
And they
I'm
weren't.
fine
They were
with
going
it.
to keep that.
You know,
and
now
then-
I don't want to do too
and
much.
strike below it, but if it only refers to what we're striking. See what I'm saying? Why keep it if we're going to strike it?
I mean, I just incremental, try to,
Yeah, and
I mean,
I don't
I
really-
don't want to open it up. You don't either. I know what it does. but just-
I don't know whether I would change in final state. I don't know whether I would change that to just that they have severe disease or not. I don't know. I don't know how you would go to it. I can understand about the stages because that would
Yeah.
I'm sorry, I don't, Patty.
All these legalese, it's just over my head.
Thank you to the
Representative
lawyers.
Kelly for a friendly amendment.
I was going to amend your amendment. I feel like we're in judiciary.
We are,
Chair. So I would just say the very first part of your amendment I agree with completely. I think at 268 should read, no licensee shall advertise or market medical cannabis or products to registered patients or the public. Period.
Okay.
And then I think you need to pick up on 271 and just continue the sentence without creating a new paragraph that just says, a licensee shall be authorized to provide information regarding its medical cannabis and products directly to physicians and healthcare providers, period.
Yeah.
And that's where we were originally with just the name change of oil to medical cannabis.
Yeah.
Okay.
And that would be my amendment to the amendment.
Is that acceptable?
Yes.
Chairman Cooper, okay. Does everybody have this now? We're all on the same page? Oh, okay. Go ahead.
So beyond that, are we keeping 3 lines 276 through 283?
I think your amendment cuts those
I
out.
would just cut everything from 274 to 283.
Yeah. Yeah. Take it all out.
Okay.
So the amendment would be.
You good with that? Representative Bennett? Yeah, we have a second. Let's get through this one first. Okay, I've got number 7. I'm not sure that.
Yes, that's me.
Mediac? Okay, go ahead.
Yes. I hate to put a monkey wrench into this, but I like 74 and 75 about the legal and safe uses of medical cannabis and products to registered patients or public.
No,
Why?
or the public.
That was
Well-
Representative Clark's.
Oh, I'm sorry, I was talking. Take out public?
Yeah, the public is
So it would be registered patients.
But then that completely changes the amendment we just made.
Yeah, I know it does. I know it does.
I had a couple of us work on it.
Yeah, that's where I'm going. Mr. Chairman,
Yes, sir.
would you be amenable to come back with a sub on this, and let's get all this stuff straight?
I'd be happy to.
And I would like for you to also consider the lupus,
Yeah.
the Q, section
Would the
Q.
committee be amenable to lupus?
That's a suggestion. You're the one going to come back with the bill.
Okay. Okay.
Sounds good? Chair Lady Cooper, I bet you have something else to say. Can't get your microphone on. There it goes.
Since we're moving along in the session and we're told to get some bills out, would it maybe take another week and a half or more to get this done? And if we be glad to withdraw my original amendment and let the two lawyers here
Yeah.
put it together, like, would that,
I think they could have it ready by next week. Do you have a problem with that?
no, it's
Okay,
not my
yeah.
deal. No, I just.
All right, so we're in agreement.
And I'd like to put my amendment in, please.
Yeah. He's going to work on that.
We'll get it in the sub.
Yeah. Okay. You have another question, Representative Bennett? You're through? Okay.
acknowledged.
I'll withdraw my,
You withdraw your amendment? How about,
Do something quick.
yeah.
I'll withdraw my amendment to the amendment if Madam Chair wants to withdraw hers as well.
I do.
You want to withdraw yours also at this point?
I don't think you ever recognized her to make it.
You do.
Well, yeah, you're right. I was going to, but yeah, you're right. In fact, I said something to him about Q, but anyway. So right now, we're standing at the suggestion of withdrawing the motion on the table and all the seconds, and you're going to come back with a perfected bill, a substitute.
I'll work with you, Mr. Chairman, yes,
All
sir.
right. I think we can do that next week.
And other members of the committee.
Okay. We still have a motion to pass. Do we want to withdraw? Whoever made that motion, they want to withdraw the motion? Who made the? Okay. Okay. All right. We are adjourned. Thank you.
Yeah, because.
They said leave